There are currently 4 monoclonal antibodies that target the CGRP system. 3 of them are already available and have been approved by the FDA. One of them is in late-stage development. That one is eptinezumab. 3 of the drugs target the CGRP ligand. One of them, irenyumab, targets the CGRP receptor. 3 of the drugs are given subcutaneously. One of them is given intravenously. I think it's fair to say when we look at the class of drugs that they have some important benefits in common. So they are all very rapidly acting in comparison to conventional oral therapy. They all have very favorable tolerability profiles in comparison to conventional oral therapy. They're all relatively easy to use because there's no need for gradual dose escalation to manage adverse events. So as a class, these 4 agents have much in common. Irenyumab is unique in that it is the only drug that binds the receptor, so there's a hope that there'll be people who respond to receptor-targeted therapies who may not respond to ligand-targeted therapies and vice versa. So I think in comparing the monoclonal antibodies, one important point of contrast is, do they target the receptor or do they target the antibody?
Fremonizumab is a CGRP peptide monoclonal antibody. It's been studied in episodic and chronic migraine, and it's effective in both. It was studied in 2 dosings. One as subcutaneous monthly dosing, and a second as a quarterly, you might say triple dosing every quarter. It's effective, it's well tolerated, and there are no significant adverse events. It's with regulators at the moment, as I understand, and we should be hearing in the not too distant future. Ubrogepant is a small molecule CGRP receptor antagonist that had a phase 2 dose ranging study and has had 2 phase 3 studies called Achieve 1 and Achieve 2. They were both positive across the doses. It's effective at the 2-hour pain-free mark and effective against most bothersome symptoms. So this is where patients pick out nausea, photophobia or phonophobia and have to hit that at 2 hours as well. And they're taken as a co-primary by the FDA for licensing. So that those co-primaries were positive in both of their phase 3 studies, which were in excess of 500 odd patients per group, clearly effective and well tolerated. Really no particular side effects of concern, and certainly nothing is emerging in terms of abnormal blood tests for liver enzymes in particular.
We know that galcanezumab has in its label improvement in functional status using a measure called the migraine-specific quality of life. As far as I know, fremonizumab doesn't have quality of life claims in labeling. They used several instruments. They used the migraine-specific quality of life questionnaire, and that shows that fremonizumab improves health-related quality of life. They also used a measure called the WPAI, which measures workplace productivity, and using that measure, they demonstrated that fremonizumab not only improves quality of life, but reduces lost productive time and increases productive time at the workplace, presumably by decreasing headache frequency. And of course, when we treat migraine, it's important to think about treatment as not just targeting the disease, but targeting the person in all their daily activities, and function at work is very important in migraine because migraine is a major cause of workplace disability. So preventing migraine attacks has as one of its major benefits reducing lost productive time and increasing workplace productivity. across the development of CGRP targeted monoclonal antibodies, sponsors did studies that enrolled patients with episodic migraine and chronic migraine. Episodic migraine, of course, is defined by less than 15 headache days a month, and chronic migraine is defined as migraine with 15 or more headache days a month, at least 8 of which show some link to migraine. So for all of the agents across all of the studies, the agents are effective in episodic migraine and they're effective in chronic migraine as well. The studies did permit people who had tried and failed other preventives. Some of the studies allowed people who were currently taking prior preventives to enroll, and in those ways the patients are similar to the patients that are seen in clinical practice. Now, one point of departure is that patients who have tried and failed multiple medications, so the patient who's suffered for years, who's been treated in subspecialty care for years, might have failed 5 or 10 prior preventives, and those patients were ineligible for the study. And of course, that's a common design decision that sponsors make running trials, because there's a fear that if they enroll patients who are refractory to absolutely everything, the patient may be refractory to the study drug as well. Now, as it happens in clinical practice with Arenumab, I'm now giving those patients Arenumab and seeing results that are gratifyingly positive. So that departure, that disparity between who gets in the trial and who's in my practice, does not seem to render the trial results inapplicable to the patients I'm treating in practice. And the very refractory patients I'm treating are often, although certainly not inevitably, responding.
The studies with galcanezumab, the CGRP monoclonal antibody to the ligand, in cluster headache, in episodic cluster headache, we've just seen at the American Headache Society, the study was positive. So there's a clear possibility to use CGRP targeting in episodic cluster headache. Interestingly enough, the chronic cluster headache with galcanezumab, chronic cluster headache study with galcanezumab, and the chronic cluster headache with study with fremanezumab seem to have failed. So that's a differentiation we're going to have to understand. The upside would be that if one could develop the small molecule receptor antagonists, perhaps in an appropriate way for acute treatment, and the monoclonals seem to have a short-term, the preventive effect in episodic cluster headache. So there does seem to be some headway that we'll be able to make in cluster headache, particularly episodic cluster headache, with this CGRP mechanism.